Okay, and welcome everyone to the PFCC Partners Community of Practice Workshop. I hope you all are well and appreciate you taking an hour out of your Friday afternoon to join us today. My name is Lindsay Galley. I'm the Director of Education at PFCC Partners and very excited for our presentation today. We have Bruce Spurlock, who is President and CEO of Cynosure Health, joining us to talk about utilizing a social vulnerability index to identify community needs. So I will pass it to Bruce in just a moment. As we get started today, I have a good reminder here to turn on live transcript for anyone who needs it. So live transcript is now available and you can access it by clicking, I believe there should be a CC on your Zoom toolbar. Everything else on your Zoom toolbar is also accessible to you as well. If you have any background noise, please mute yourself. If you have questions that come up throughout Bruce's presentation today, you can put those in the chat. I will be monitoring the chat and can bring up any questions that come up throughout the presentation. We will also have some time for Q&A at the end as well. If you haven't done so already, please take a moment to introduce yourself in the chat. I see folks from all over the country there, so thank you all for joining us. All right, we are also recording today's workshop and the recording will be available on our website by next week. So if you missed something and want to go back, you can do so, or it's just fantastic, which it will be, you can pass it along to your colleagues as well. And again, we are PFCC Partners. Our organization has a mission to center the inclusive human experience of health through radical collaboration and really be a catalyst for system transformation. Our vision for the next 20 years is a health system that's completely transformed, one that works with people and through communities as a partner in their well-being. We also recognize that equity, inclusion, diversity, collaboration, and being solution focused are all ways that will help us achieve that vision. Our organization also fully supports and facilitates the Patient Family Advisor Network, a network of patients and family caregivers serving in the role of patient family advisors and partnering with healthcare organizations, all in an effort to improve how healthcare is delivered and improving outcomes as well. If you are a patient or a family caregiver, we encourage you to join us and are happy to share more information about the PFA network in the chat. All right. I didn't want to take too much time with my introduction because I'm very excited today to be joined again by Bruce Spurlock, our fantastic partner at Cynosure Health. We are really grateful to be able to bring patient family engagement to Cynosure Health and all of the hospitals that we get to work with in partnership with Bruce and the rest of the team at Cynosure. But very excited for today's topic. Bruce is going to talk to us about utilizing the social vulnerability index to identify community needs. So where that data comes from and how it can be used. So Bruce, I will go ahead and pass it off to you. I'll stop sharing first.
All right, great, thanks. Thanks, Lindsay. Let me bring my screen up so that I have this ready to go. And then I just want to say first, before we get started, I can't tell you how interesting and different the world is with PFCC partners embedded right with us and patients embedded in how we're operating our HQIC. This is the 300 hospital network across the country in 11 states. We're just, it just like it's right and left hand. We fit together so nicely and it's part of the same work. And it really has changed the dynamic from what we used to think about with patient and family engagement and equity now to, it's just how we do quality improvement anymore. It makes a big difference in the long run. And there's increasing number of academic studies that prove that. So I'm glad we're able to kind of extend this. And I know that we have a broad and diverse audience today. I know that diversity means a lot of different things to a lot of different people, including sort of technical capabilities. So I apologize. I'm going to speak data a lot. Some people call me a data nerd. My daughter calls me a data nerd. So bear with me. If there's a problem, raise your hand. I'll stop and I'll try to remember to stop throughout the presentation, so we don't have to save everything for the end if I'm not being clear. And again, if you're somebody who's deeply embedded with this, which I think there are a couple of on the phone call now, please write your questions in the chat or save them till the end. We're happy to address those as well. So we kind of discovered something about a year ago now. It's been about a year we've been working on this, started in California. Now we've expanded to all the 300 hospitals in 11 states. We've done even more work in Florida as we've tried to tease out some of the interesting things with some data sources in Florida that we've been able to have. And again, the interesting part about this work is every week, a new discovery is coming up, a new aha insight. So we're far from saying we understand it. We're far from saying it's perfect. We're in this like light bulb session, and hopefully some of those will go off in your eyes and your head, and that you'll be able to contribute to that, because we're just scratching the surface with this idea of how to think about the community that a hospital serves. The people and the population, not just from the ones who show up in the hospital, but the ones who potentially could show up at some point in the future if they were to get ill or have a need for hospitalization. So that's kind of what we're talking about. I've shown this slide to many people. This is common. Many of you have seen it. There are actually probably better descriptions of the difference between equality and equity, but I want to make a point out of this. And the goal that we're all heading for, and where the buzz is right now in healthcare, is on health equity. And it's this notion that we get the outcomes that people deserve based on the needs that they have, and not necessarily based on just some arbitrary level of what we think access is or opportunity. The question that's been bugging me, and that I've been scratching my head about, and I think we're starting to peel away a little bit, is what's this? What is the box that really makes the difference? And it's one thing to talk about. It's one thing to see disparities. It's another thing to say we know what to do, or we think we know what to do. And a lot of people are saying we're starting to think we know what we need to do, but I'd like to get at it much more rigorously, much more like a scientist. Although I know that there are non-scientific aspects of it, I really want to tease it apart, because that's kind of what we do at Cynosure. We understand the ins and outs of it. So let me just start off by saying, and there's a big movement on this, that capturing individual patient information is extremely important. And in fact, the Biden administration has said in CMS, there's a proposed rule that hospitals will have to start collecting this in a very structured way in the near future. It's not a final rule yet, but many expect that rule to happen. So what I'm about to say does not say this is wrong or unnecessary. And I just read something yesterday said that what I'm going to talk about is complementary to this. So what we think this is where for each individual patient, you collect the social needs, the social determinants of health, and other factors that do impact the healthcare and the health outcomes they have, so that we can think about a prescription that we write is more than just a drug or a surgery, but it's really about an intervention that improves outcome that is more whole person or more person-centric than simply that prescription that's on a prescription drug pad. The challenge we find with collecting this level at the individual patient, and I know some of you are interested in this because this was questions that you put into when you register for what you're interested in, is that this process is not perfect. We have inaccuracy, it's incomplete data, and to be honest with you, not many people have taken action on it when they do capture it. Here's some of the inaccuracies. We make assumptions based on, let's say, the color of somebody's skin, or whether they have a certain accent, or whether they talk a certain way or walk a certain way, what's going on in their life. We sort of think by looking at the book, we can tell what the chapters are on the inside of people. And sometimes when we open up and look at the chapter titles, people don't want to tell us. They're unwilling, or they're nervous, or they're scared. How is this data going to be used? How's my answer? If I answer this way, will they treat me differently? And so there's inaccuracies in the data that we capture in this very human process of asking questions about sometimes very intimate topics like violence in the home, very intimate topic. And we're expecting people to give us perfectly accurate answers on a routine basis. I think we know that's not true. We know that it's costly to do this. I can't tell you how many doctors' offices I've talked with who desperately want to capture this information. They get the connection between the social determinants and other factors that affect the health of their patients, and yet it's very costly. They have to develop new workflows and new systems. The electronic health records don't capture it the way that you would always want to easily get it. So there's some incompleteness to that. And then we just really haven't taken action on what we do know, partly because we're not sure if we can do anything about it. So yes, it's important to do this. There are groups that study this about collecting social needs from individual patients, but I'm going to look at it through a different lens. The lens I'm going to look at it is to say, what if instead of looking at the patient level, what if we looked at what people are calling the neighborhood, or what I'll call the community? Can I describe the community that a hospital serves and the social vulnerability that that community has? So it's one level up. It's not the patient, it's at the community, or what some call the neighborhood level. And I like to think about this as knowing your neighbor. Can I help a hospital understand its neighborhood? And I think that's what we're getting at. So it turns out probably complementary. Neither one's good or perfect. They kind of help each other when we're thinking about solving this problem. So how did we do this? Well, we started last summer figuring out what we could do to look at the neighborhoods. And sure enough, there are a lot of smart people that have already done this work for us. There are these indicators of disadvantage out there. There's a number of them. In California, we have this thing called the Healthy Places Index. And the state of California used that index for reopening during the COVID pandemic, and also on vaccine distribution for health equity with COVID vaccines. So the Healthy Places Index already being used as a measure of the neighborhood need on a variety of factors I'll talk about in a second. Another one the CDC put together called the Social Vulnerability Index. We spent a lot of time on that one because that's available for all 50 states and is easily usable. The Area Deprivation Index was developed initially by HRSA that looked at workforce and those kinds of things, and now run by the University of Wisconsin. And while they're all getting at some of the same things, they're different. There's several more out there. There's the Social Deprivation Index. You could look at poverty levels. That some people look just at that, or at household income. There's a whole bunch of race, ethnicity ways to think about it. So all we had to do was pick one. Well, it took us about 6 months to finalize when we actually studied the top 3 the most. And I'm going to show you a little bit of that data, but I'm happy offline to talk with people about some of the analytics and why we are focusing on the 2 that we ended up on. All right, so this is where I start getting wonky and nerdy. So please stop, raise your hand, type in the chat that this doesn't make sense if you're struggling with it. So let me make sure I have the chat up so I can see what's going on. All right, so this is how the Healthy Places Index was done in California. It's 8 domains. So 8 sort of subject areas. And with each of those subject areas, there's 2 or more questions or measures that make it up. For you techie people, this is called a composite measure. We label it an index, or they label it an index like others do, because it's trying to get at the sum total of social needs and not just individual categories of social needs. And if you see them, there's economic, education, healthcare, and social transportation, all of the 8 categories. The number underneath them is how epidemiologists that created this weighted each category based on its expected impact on life expectancy at birth. So it's a sophisticated statistical model that really smart people get around and crunch a bunch of numbers, and they're saying the economic factor is 32% of the impact on life expectancy at birth in this geography, in this neighborhood. So that's the outcome they're looking at. What has an impact on life expectancy at birth? There's some questions about, in the hospital setting, is this relevant? But this was really smart people that did it, and we're using in California for a variety of needs. It also means things like transportation may be more important than we thought because of its impact on life expectancy at birth and social needs. So again, this is a composite that tries to get at sort of a greater whole of what social needs are from a sort of statistical method. Gray, you have a question.
Yeah, so the numbers on the top, that's a proportion.
That's right.
Okay, because I didn't see any scale or anything on there to indicate that. So thank you.
Yep, great. All right, so let me go to the next slide. This is the other one that we spent the most time on. Again, we studied the top 3, the ADI in this, is the Social Vulnerability Index. And the main reason is because the CDC did this for the entire United States. And both of these are at what we call the census tract level. And the census tract is like a geographic definition. It has about roughly 1,500 people that live in it. It can be a little bit higher, a little bit lower. There's some geographical components to it, but it's sort of the way that both the CDC and HPI and others have sort of said, this is the smallest unit. If you add up census tract, they become a zip code. If you add up zip codes, they become a county. If you add up counties, they become a state. So it's one of the ways to think about how these indices are created. The CDC did theirs for a completely different reason. They were looking at disasters, and the pandemic was perfect for the use of the Social Vulnerability Index. It's similar, but not identical to the HPI, to the Healthy Places Index. It has 4 major domains in it, and those domains are socioeconomic status, household composition and disability, minority status and language, that's not in Healthy Places Index, and housing and transportation, and similar of the subcategories below it. What the CDC gives us for each census tract is both the top number, the overall vulnerability, and these 4 different domains, these 4 different categories. They call them themes. And so that's the information that we can look at each census tract. So we think we have pretty good measures, and I could go into the ADI and other ones, but I'm going to spend more time on these 2 than anything else for the reasons I mentioned earlier. The second part of what we had to do was to say, okay, this data is publicly available, been thought over, crunched by very smart people. What we really need is to see if we can get to a catchment area, or what people call a hospital service area. And this is where people live who come and utilize the services. Because if we can take like what their neighborhood is like, where they live, and then sort of slice and dice that up into what the hospital is serving, then we can actually sort of think about putting those together. There turned out to be several data sources for this. The first one we found was something from Medicare fee-for-service claims, for those of you wonky people. In California, we have an organization that's a state agency that produces what they call a patient origin file. And what these are is they're just saying hospital A gets two patients from zip code 90001, 6 patients from 9002, 85 from 9003, 132 from 9004. And from that, we can kind of create a service area map. We've actually tested this with many hospitals, and most hospitals think in terms of primary and secondary service areas. These are like where the people come from, and they're matching up with what we're getting in our data using this. I have the ACA one for those folks from Florida. We used record level data out of ACA to be able to create the hospital service area. So once we have a sort of geographic hospital service area where each of the patients are coming from, the next step is to merge them together mathematically. Not very hard. It's pretty basic math. It doesn't require a lot of sophisticated statistical manipulation. But what it allows us to do is to give a score for a hospital. In this case, you see what I put up here is at the HPI score. And the HPI score is just like, it's a number that's meaningless, a number that doesn't really mean anything. What's really relevant is the ranking, right? Is the relative performance that you see up here. So in this one, you can see Martin Luther King Jr. Community Hospital. Some of you might know that. That's an urban hospital in urban Los Angeles. It's racial ethnic makeup is like 82% Black and brown people. It's obviously in a very poor community, and it's got the lowest scores. So lower in Healthy Places Index means lower health, and higher in the SVI means higher vulnerability. So you have to think backwards on these 2 scales, but we tried to match them up and color code them. The SVI is the same mathematics. We just did it with instead of the Healthy Places Index, we did with the SVI. And hospitals move around a little bit. And if you're interested offline, I'm happy to go with what we did, the R squares that we got when we compared how many hospitals move and how far they moved and what the predictability of this was. It turns out that the HPI and the SVI are very close. But the HPI and ADI, and even more, the SVI and the ADI, for those of you in acronyms, are not as close. So the HPI and SVI get at some of the same things in roughly the same categories. But the ADI, the one that comes out of the University of Wisconsin, is a little bit different, not completely, but substantially enough that we thought, let's stick with the 2 that have this vast amount of agreement. All right, so here's the other point about this slide, is you see Adventist Health Clear Lake is number 2, the second lowest. So Martin Luther King, urban, inner city, predominantly Medicaid, Medi-Cal in California, black and brown. Adventist Health Clear Lake is Northern California, rural. So any of you have been in the Clear Lake area, you know it's pretty challenged in that community, mostly white, like 92+% white people that live in the Clear Lake service area for Adventist Health Clear Lake. So what this kind of like was the big aha for us, like the HPI is looking at social needs a little more comprehensively than just simply Medi-Cal or Medicaid percentages and race and ethnicity. And in fact, these two hospitals kind of keep going around each other a lot. And a lot of what we see is a lot of rural facilities are extremely challenged in the healthiness of their community or the social needs in their community. Here you flip it on the other side, and here's where the healthiest or the lowest social needs are. And most of these are in Northern California and the Bay Area. And again, the numbers aren't meaningful. What's important is the ranking and where these are. So you might consider these like healthy hospitals or healthy communities with low social needs and where we should be paying attention to. So this is just a little bit of the early work. Here's something else that was kind of a big aha for us. When we talked with our Healthy Places Index colleagues, they knew this, but for many of the people we talked with, it was a big aha. So this takes that score and puts each one of those hospitals as one of these gray dots. So each gray dot you see on this screen here is an individual hospital based on their HPI score. And then we have 14 sort of markets or geographies, mostly Northern California on the left, Southern California, right? So it goes from north to south. The X's is what the average is. And what you can see is the central, which is the Southern San Joaquin Valley. That is the lowest HPI score. Big aha for all of us. We thought Los Angeles was going to be the lowest. Los Angeles, number 11 on there, you can see that one. That has a wide range, but overall, it has a higher level HPI score as a region. But within that region, there are some very low scores, a number 11, and then some very high scores. So tremendous variation. But if you just look at the central one, you know, it's challenged as a geography. If you're a policymaker, if you're thinking about where do we tackle problems in California, it's like Central Valley. Go to the Southern Central Valley. That's where the greatest needs are from a policy statement. It doesn't help necessarily at the hospital level, but certainly for policymakers, it makes a difference. All right, here's the other big aha that we did. Once we were able to give a score to hospitals, we know what hospitals' performance are on quality measures. And so we said, wow, how much of these quality measures are implicated by the HPI? Or for your techie people, the nerdy people like me, what's the correlation? A correlation doesn't mean causation, but it means that there's a relationship. There's some kind of connection between these two. And so we looked at our 84 measures and we did the correlation coefficient. And you can actually see we have the HPI correlation, the RPL is the SPI correlation, and here we did the ADI correlation coefficient. So we looked at this for all of our different indices out there. And I highlighted those ones because this is a hard graph to look at, hard page to see where we see something that's really interesting to us. So the number one is breastfeeding, and it's breastfeeding across the board. Breastfeeding has the strongest relationship, doesn't mean causation, but just means relationship with the HPI score. That kind of interesting. And then the other boxes I had are what we'd call HCAP. So for those of you who don't work in the world of quality improvement, this is patient experience. These are measures of what patients experience in the hospital, and they look moderately correlated, not completely. It's not a 100%. So it's not saying the social determinants are, you know, like predicting, they're just part of the equation. Whereas breastfeeding, 57% or so, that's a big influence. If it truly is causal, that HPI and breastfeeding are related, that's a big deal. We should be able to do that. And here's it on the other side. If you flip it around and we look at numbers, like I said, better is lower, better is higher. This one, better is lower, it's negative, but the readmissions that we thought for a long time are correlated with social determinants, in fact, are correlated, not completely, right? So this is a 31 for those of you who look at 31% correlation coefficient, which means that it's about a third. It explains about a third of the performance, but not really 2/3 of it. And that kind of makes sense. What that would say is that what happens in the hospital, what happens after somebody leaves the hospital, what the hospital does in that transition has an influence that's probably independent of people's social needs. But people's social needs probably end up, no matter how good a hospital is, the social needs that they're sending somebody back into, that neighborhood probably has a relatively large impact. Okay, I think Natalie asked a question about this. Let me see. Is this the lack of breastfeeding? It's breast milk feeding at discharge. So there's a big push, as many of you know, to get moms to do breast milk feeding, exclusive breast milk feeding at discharge. We measure that in California. Some other states do as well. We track how well hospitals perform on breast milk feeding at discharge. It doesn't mean they have to be breastfeeding. They could be pumping. So this is for like folks in NICU and other places. They can be using breast milk through the bottle and those kinds of things. But the goal is
for men who give birth.
Yeah, exactly. There's a lot of health evidence that breastfeeding is very good for babies with immunity and other activities. So that's kind of what we're measuring with this. The other part that I wanted to show you is we do a lot of things in quality improvement that probably at the state level aren't correlated. So I've outlined here what measures do not correlate with social needs. This is really, really important. And you'll see that some of the infections that we've talked about, that some of you that we're doing with our H-Quick are not really correlated. And the NTSB C-section, for those of you, again, who don't live in this data world, that's low risk C-sections. Those are the easy ones that moms probably should be avoiding C-section unless there's specific medical indications. And we work on that. We thought that there was a lot of connection with that. And it turns out at the statewide level, it doesn't. Now, let me just pause. And I always like to do this. At the hospital level, there may be a correlation. So there may be hospitals where social needs are playing out any one of these, especially something like C-section. You could see where social or racial or other kinds of influences would change the rate. But as we add them up across the state, we can't see it. So what that means is individual hospitals need to know, this is where I was talking about that one level where you're taking information at the patient level is very valuable for the hospital. But for policymakers, it's like, maybe we shouldn't be using C-sections as our measure of whether what we're trying to do with disparities is making a difference. So that's another one. Anne had a question. Is maternal depression and maternal health stress level measured and correlated? We don't have that in our data. That's a very good question. And we don't know if that exists, although we assume, because there's a lot of research suggesting that it does. I just have not been able to get to that level. So thanks for that really interesting question. All right, a couple more things. I'm going to focus a little bit on breastfeeding because now we're talking about, I want to get to that box. If you remember my very first slide, I said, we want to know it's that box that gets to equity. So we're starting to see maybe some measures have more influence on equity than other measures. This is one of the ahas. Let's take breastfeeding and say, how do hospitals do with breastfeeding that have challenged communities? So this 1, 2, 3, 4, these are quartiles. And the ones on the left are the most challenged HPIs, the most challenged hospitals with the least healthy communities. And the ones on the right are the healthiest ones. Those are Northern California ones. What you see on this, if you do a little bit of analysis, is that we have bright spots. We have hospitals that are working with challenged social needs populations and doing a great job. We should understand what they're doing and spread it to everybody else. And in fact, we've done it. We know who these hospitals are. We're starting to interview them, ask them questions. We've talked with the breastfeeding coalitions here in California, but we're starting to say, now this data gives us clues on how we might think about getting equity with breast milk feeding at discharge, irrespective of your social needs. So that's our first kind of way to look at this. Mark says, to what extent does breastfeeding measure serve as a proxy for health literacy? Good question. One of the things we know is that when you look at, in California, at breastfeeding, there are hospitals with high language challenged and high racial and ethnic backgrounds that have cultural impacts on it. And there are ones that do a great job and not a great job. And this is suggesting that those things have a factor, but somehow people have been able to get around that. They figured out the magic, the secret sauce to overcome those barriers. And so that's what we're after. It's not like, can we identify every barrier? Can we identify the solutions that PFCCpartners talk about? Let's be solution oriented. How do we get over those barriers? And we think these hospitals have figured that out. So that's our first use of it. The second use of it, I've got 3 uses that I'm using right now, and I think they're going to answer some of your questions. The second use of it is to help hospitals understand their neighborhood. So we created a mapping tool in California. We're about to do it in Florida, and then we'll eventually do it in Montana and other states as we get more data. We've created a mapping tool so that we can start looking at this by zip code. So here is a map that shows a hospital that I worked with, and we actually got them on the meeting and met with them and showed them the data. This is Valley Presbyterian Hospital in Van Nuys, California. They were really interested in this. They said, yeah, right, we're showing you now is their service area. This is where the patients come from. They go, yeah, this looks like our primary and secondary services. These maps map to what our maps look like for primary, secondary service area. This is where the dark red is where most of their patients come from. And as you look over California, and in most communities, most of the patients go to the local hospital. But there are some people that travel some distances to get there, whether they work there or whether they got in an accident or whatever. There are some people that come out, and that's the secondary service area. But what's really cool about this, and I don't have it set up, but we can actually break this down and we can look at this by those 8 domains in the Healthy Places Index. Now we start getting at some interesting thing. And what we show here is these little bumps that you see on there, these color-coded bumps, that's California's distribution of the overall HPI, of economic, of transportation, of social, where hospitals for the entire state lie. And the little dot there is where their hospital is. And what you can see for this hospital, their areas to focus are in healthcare, that's in cost and coverage, in housing, and in social needs. They don't need to spend as much time in transportation because they're right, we're kind of in the median. Van Nuys, there's lots of transportation opportunities. They're not geographically isolated. So now we start, I showed them this, and we actually walked through the different layers. We walked through the housing layers, we walked through the, so there are housing layers on this tool that we can use. And they said, I knew this area was rich, but I did not know this area was as challenged from a housing standpoint as it was. We showed this to folks in Santa Barbara, and they go, we thought we knew where our housing challenges were completely different when we had a map on it. So now you're starting to say, okay, this may be where you think about working from. Here's this other hospital I mentioned. This is Adventist Health Clear Lake in Northern California. Here we have it by the HPI score for a community. And so you can see the dark purple, there's a graph on it. That's the neediest, the burgundy wine color, if you drink wine, that's the neediest area. So the hospital is the little blue one, but where the most challenged community is that dark purple one. And in fact, whereas the gray and stuff is not as challenged very much. So this starts telling the hospital, when you look at all those scores, that's where the issues are. Gary said, are you guys using Esri mapping software or Tableau or a different map? This is, for you geeks out there, this is our Shiny apps, and it's using R coding. And believe me, we're deep into how do we do this in other states and other areas. It's not that difficult to make this happen. And then Linda says, are you mapping only the neighborhood surrounding signage or hospitals or the entire state? We have maps for the entire state, but we show the hospitals what's relevant for them. So what we want hospitals to do is to say, when we're thinking about our community health needs assessment, we know our neighborhood. We know where the economic needs, the transportation needs, the social needs, the pollution, neighborhood, all of that kind of stuff. In the SVI, we want them, we know the socioeconomic status, we know housing and transportation, we know racial and social, we know that for our community. And we know it to a level that we didn't think we knew before. And more importantly, this is the part that was the big aha, we know where it is relative to others in the state. So we always thought we had a challenged community by this, but based on where we are in the states, that's not our biggest issue. Our biggest issue is XYZ. So see how we're trying to get to this boxes underneath it? And here's where they need to focus on theirs. The last one I want to show you, and again, if you want to ask a question, just raise your hand. This is Martin Luther King Hospital. And Martin Luther King has the lowest score. And we asked a different question of it. So here, this is the map that shows their primary and secondary service area. The dark red is where most of their patients, orange is a fewer of their patients. light yellow is where less, and the lightest yellow is where like 1 or 2 patients come from each one of those zip codes. So that's their primary and second. And again, we got a Zoom meeting with Martin Luther King. It was supposed to be a half an hour, it was 2.5 hours, and they were eating the stuff up because this was matched to what they're doing and gives them new insights. And again, we have this stuff on the left here that gives that, that over here on the left, we have the specific needs, and you can see they're off the charts in 4 or 5 different areas. Okay. We asked a different question though. We said, Martin Luther King, you're in this zip code. What if we look at what other hospitals are in that zip code? Sure enough, in zip code 90044, Martin Luther King takes care of 12% of the population. But Centinela Hospital takes care of 11%. Memorial takes care of, and if you think about this, 7 hospitals take care of over 57% of the people in that zip code. And what that really means is Martin Luther King is not solely responsible, nor should they think about addressing a zip code by themselves. That this is the real opportunity for collaboration among hospitals. Now, this is harder in a rural environment because I think I showed you the Adventist Health Clear Lake. They're responsible, they're like 74, 70, 80% of the hospitals in those zip codes. So it's like they own it. In more urban areas or where there's more hospitals in a smaller geography, this is where we might see some opportunities for collaboration. Let's see, Mary says, have you considered combining ambulatory clinic info to your analytics? Receive long-term care from both hospitals and clinics. Mary, great question. We'd love to do that. We don't have good ambulatory clinic data, although there's some opportunities that I'll talk about in a second. What we did just recently was we looked at EDs and we looked at opioid measures, and we looked at how many opioid-related ED visits and how many opioid-related deaths are in zip codes that could be then painted into that hospital. And how can we tell the hospital, this is your opportunity from opioid use disorder in your community, and how are you addressing it? Because a lot of people know when somebody shows up that they have an opportunity, but what they don't know is when it's going to show up next week, and how do we intervene more quickly with all of that? So let me just show you. I'm going to show you. This is not Arizona. I wanted to show you one more use of this, and then I'll stop and we'll get some questions in here. And this was a question that somebody asked, several of you asked in the in the registration process. You're collecting individual patient level data in your hospitals or in your communities, and most people do this, right? Hospitals collect registration data, and they have categories for race, ethnicity, for example. The question is, as I said, sometimes that data is not good for a whole host of reasons. We make assumptions, patients are unwilling, they want to answer a certain way because they think they're not going to get the same care. We might have a method to test how valid your ability is to be correct. So we created these indices were created with the American Community Survey coming out of the Census Bureau. So the Census Bureau every year, and on every 5 years, they actually aggregate it up. So they refine it more on a 5-year basis. But they say for these census tract and then these zip codes, you should have X% of people that meet that are white, X% that are Black, X% that are Hispanic. You know, this is what our survey says that you should have in these zip codes. Using this method, we're going to have data available that says, this is what we expect in your community based on the American Community Survey. This is what you submitted. This is what you told a state agency, whoever you submitted claims to, what their race, ethnicity was, for example. And if this is percent Hispanic in Florida, so we have Florida data, and the hospital collected that percent Hispanic on every patient, and that was discharged in Florida, sent it to the state, we got it. And we said, does your percent Hispanic match what we predict based on the ACS? And you can see that if everybody was perfect, they would lie on this line. If there was a 100% matching, they would lie on the line. When the further somebody gets away from that line, the more likely there's something quirky going on. And quirky is not accusatory. Quirky might be the American Community Survey. It's a sample. Quirky might be you're collecting it weird in the hospital. It's the further you get away from that line, the more likely you say, we better go and recheck what we're doing and seeing if we're getting it right. And it doesn't point fingers, it doesn't give you blame, it just makes you scratch your head. So it's a way to validate what you're capturing using this neighborhood information. Lindsay says, this is fantastic work. Question about using census tract. In some communities, the census tract split neighborhoods. That's right. Is there a way to account for this issue or similar problems? Woo. You now are diving deep, Lindsay, into this work that epidemiologists spend their time on. It gets more complicated. There are ZICTA scores. Instead of zip codes, it's ZICTA because zip codes kind of move along. Census tracts change a little bit from time to time. The level of precision is challenged. However, we have ways statistically, just kind of like we're doing now, to be able to say how much confidence do we have about the census tract or the zip code, how much heterogeneity for those of you nerdy people out there that we're able to do. These are all the stats we learned in grad school for biostats and epidemiology. Yeah, absolutely. I'm a doctor, I'm not an epidemiologist, and I'm learning tons from very smart people that teach me about this. What we're saying is that this is never going to be perfect data. And I've already told like health plan people, don't think about using this for payment purposes. It's too early, too unrefined for us to be able to do that. But it gives us clues. It points us in the right direction. It makes us scratch our heads. This is data. Here's another one. This is percent African-American. Look at that. A lot closer to the line, except for this one outlier. So this one hospital, according to Florida discharge data, they report they're having like 48%. We predicted them that to only have like 15%. So we could be wrong, and we as the American Census Community Survey, or the hospital could be over labeling it for whatever reason. And we don't know the right answer, but it makes us scratch our head. And here's the one that really got, when we looked at any non-white, there was one hospital that said 100% non-white, and we would have predicted that they would have had like 15, 20% non-white. So something's really askew, and it could be us. This is one of the ways we're testing out our method for doing this, but it's also a way for hospitals to think about validating their information. All right, let me stop and see if there are questions, because I know people have been writing in there, and I've got some more things, but I want to pause on the technical nerdy stuff, see if anybody's got any questions on that. All right, I apologize if I put somebody to sleep. And again, I'm happy if people offline want to go into more. If you're really super into that, I can show you all the scatter plots and stuff for what it looked like for ADI, SVI, HPI. I can show you when we do fee for service versus all pair, where the source of all pair was, all those kinds of things that gave us more confidence of us. I still have question marks about whether our method is perfect. And it's probably never going to be perfect, but whether it's good enough. And so I'm saying this is useful, this is helpful, but we're still have question marks about whether we're doing it. And some of the question marks have to do with the life expectancy at birth, right? So HPI was put at life expectancy at birth, and CDC, it's about pandemics and crises. What if we used other markers? Would we get a little bit different, and would it be more useful, especially for hospitals, as they think about, we're not really making those chronic changes, we're doing more acute kinds of things. And while we haven't a role with chronic stuff, where's our role and what should we be looking at? So I still have question marks. And like I said, we're learning all the time. This stuff we did on opioids and the ED was so eye-opening. It was really, really interesting to see how it works. But I think we can say that we're starting to get our arms around the fact that we can profile in a relatively rigorous, objective, mathematical way what's going around. The other thing we know for sure is that social needs are super complex, and to reduce disparities, we got to understand that complexity. We cannot shrink from complexity. We have to dive in and swim in that complexity. And that complexity is often local. What's good for one community may not be good for another. I mean, that's part of the thing that scares me about some of the policies we think about. When we make policies, they're well-intentioned, really smart. We thought about them a lot, but we don't necessarily know exactly what happens in the local community where there's these variations that are extremely important. And then targeting interventions is going to need this super local piece. And one of the things that Libby and Lindsay and the team at PFCCpartners have really beat into me is, Bruce, this is data. And I'm absolutely in agreement. This is only data, and data should only be the conversation starter. It should not be like the evidence, like this is the truth. The truth is really what community-based organizations, the people who live in that community, what they see and live and experience every day, the trust that's going on with them and their providers and the other components of the healthcare system. And then the data sparks conversations. I just went to this presentation. I saw a report. Our data says that housing, and it looks like housing in this code. What are you guys seeing? How does that gel? Oh no, it doesn't make this is a homeless place over there. That data is wrong. Well, that's the cool part, is that then you can start uncovering things that you might not even thought about, that the data helped raise the awareness in those areas. So it's really, really important. So I think we're starting to get to that box, but we have a ways to go. And I don't want to make any bones about it. I'm not even sure that hospitals can always be the right tool to make inroads in some of these social determinants. So that role is to be determined. But I think we now have this benchmarking relative performance, which is very useful, and we can do it objectively. We can also look at when we make interventions in social determinants, how should we be evaluating the impact? And it may not show up on low-risk C-sections, for example, where you'd think it would. It would make sense that it would, but this is evidence that it might not. And we might be able to tease out ways for people to collaborate. And if you want to if anybody wants to we can get down to the census tract, we can get down to the street level with addresses, but that's not publicly available. That's privacy protected for good reasons. But organizations could use this method on their own and really get even more granular to understand what's happening. So that's my story. I'm sticking to it, but I got to tell you, I'm open to insights and learning, because every time I do one of these, I learn something from the audience that teaches me, asks good questions, and challenges me. So with that, I'm going to stop sharing, if that's okay.
Yeah, absolutely. Thank you, Bruce. I think, this is all really exciting, and we got a bunch of questions too, like you saw in the registration, and some asking about, moving beyond identifying those social needs and then addressing those social needs. So I appreciated your comment that, it's not just on the hospitals to address those needs. It's the community-based organizations who are, supporting the community. So I was just kind of curious if, and I know this is relatively new, but if you've seen any other organizations using the data to then address some of those needs.
We're starting to see this happen. There's some private corporations that are using similar kinds of things. There are other publicly available data sources. There are some privately available data sources that you could purchase to try to get at this. It's called the neighborhood or area level social needs. And I think that's it. We're working, I see Rich Rasmussen on there. We're working with Rich and the team in Montana, because we actually think there's the rural needs and the rural indices are going to be different. And there are a couple of things that, like HPI doesn't include disability, for example, and it weights things differently. We think some of the weighting might have been influenced by certain communities. So we're looking at some of those factors as well. And the goal is, with all of this, is to get to that box. What do we do? What is a hospital in a certain community supposed to be prioritizing? And the way I look at it with that, and some of you on this call have done it or worked with your hospitals or worked with people that have done it, every hospital that's a not-for-profit creates this community health needs assessment every 3 years or so. And they use valuable data, but much of the time it's about disease, like how much diabetes is in our community, how much hypertension is in our community. That's good, but this is another lens of saying, I wonder if what's more important than us managing hypertension, because that's also something that more as a chronic disease, we should be helping focus and collaborating and maybe convening a housing thing. Hospitals are really good conveners. They're in many communities, especially a rural community, they're like the community hub. They're the largest or second largest organization from an employment standpoint in that community. And so they serve that convener role, that they can bring people around and say, we got to look at our community. We're just giving another layer of ways to think about looking at your community and what I call knowing your neighbor.
Yeah, I really like that. Looking forward to seeing more of what happens in Montana as well. That will be really interesting. Any other questions for Bruce?
And Lindsay, I was going to throw something else on the tail end of what Bruce, we're talking about. I know in the regional policy board of the American Hospital Association for our Region 8, we talked a lot about equity in our last meeting. And one of the challenges that we have is how equity is in some folks' mind. What does that mean? And in certain communities, it's not what we think it is in healthcare. It's often thought of as a divisive term. And so using some of these some of the ways that we've just talked about in terms of looking at this data and then perhaps redefining what equity means and giving it a new name even, I think can be very helpful. So whether we can move into what is a Healthy Places Index or something like that, or healthy communities, it does allow us to get in some communities in the state and in our country where equity is viewed as a divisive term as opposed to a unifying term. And so I think there's a lot that we can glean from this type of work and how it can change the way we approach this across the country. And that's what we're hoping to be able to do.
Yeah, Rich, thanks for that heads up. I did a presentation similar to this in Florida, and they said, our hospitals love it. Just be careful when you talk to the government about this term, because just exactly what you're getting at. But I think I don't think anybody disagrees that, if there are housing issues that are leading to poor health, that's not something we collectively want to address in some meaningful way. And how do we do it? There may be different policy ways to do it, but it is a challenge that we need to be facing head on and addressing it in a structured, systematic way.
Yeah.
Someone else, I think Laura asked a question. You mentioned at the beginning of your presentation that CMS is going to require collection of social needs. It's a proposed rule. They just closed the comment period last week on it, so we won't know if it's a final rule, but it's likely that CMS is going to require hospitals to start surveying their patients for social determinants of health. It's not specified what that looks like, but there are two measures that they're looking at potentially collecting. One, are you doing this with all your patients? And then two, they call it percent positive social determinants of health. What we suspect that, and the Joint Commission also has rules out this, there is this big movement to get hospitals to collect social determinants of health. It's not easy. It costs a lot of money. It's not accurate, but I think we can start teasing out some of those things. And if it becomes a final rule, then it will happen. In California, there was a law adapted, signed into law last year, that are going to require hospitals to submit health equity data. What that data is an advisory committee that literally is starting up next week. And over the next 6 months, will define what measures hospitals in California. So I think you're seeing people get at what hospitals need to do from a data collection standpoint. Hospitals do data extremely well, except when they don't. And this may be one of the areas where we have to help them get better at collecting data, like with those validation things I showed, with understanding where the use of the data is and why it's valuable and how we can tease things apart. But I think it's a step in the right direction, and we'll see if what becomes a final rule.
Yeah, there's some great comments in the chat. I see one from Sophia, agreeing with using data as a catalyst for the conversation, because there's so much more to the data, because Sophia had mentioned, the lack of access for some of those census surveys. That's a point well taken. I see a question, it looks like from Rosa. To that end, have you all found scripting or training that has helped hospital staffers better explain to patients the purpose of real data collection and SDOH factors in a culturally sensitive way? And I'll start. We actually partnered, we are the patient and family engagement contractors for Cynosure HQuick, and worked with patients and family caregivers to develop less of a script, but more of a conversation for healthcare staff to use to be able to collect that information in a culturally sensitive way. And I know that I believe Cynosure will be sharing that more broadly relatively soon. So yeah, very exciting to get that out a little more broadly. Anything else on Bruce? Yeah.
I think it's part of the solution, absolutely, of thinking about how we communicate with people and meeting them where they are, not where we are. And we all have biases. We all have these constraints around how we think and what we look at. So we're just human, so we got to accept that people are going to make mistakes, and that's just who they are. But if we can help people understand and dig a little deeper and find things, we can uncover it. And again, I'm not even thinking about like race, ethnicity. I'm thinking about loneliness. You know,
Yeah.
people are really lonely out there. They don't come to the doctor. They afraid. They get depressed, and they show up at the hospital sicker than, you know, anything, and they're just lonely. Or when I was an intern, I had a lady who, when she got into the ICU, she put her pictures up because that's how she dealt with her loneliness. She came to the hospital and put her pictures up in her room the instant she got in, so she could have her family with her wherever she went. So I'm really interested in how we tease out these things that are actionable, that we can make a difference on.
Yeah. And Mary has an interesting question. Do you think the transportation importance in California HPI is an indicator of supporting telehealth and digital capabilities?
You know, Mary, that's one of the interesting things I'm really looking forward to in Montana as we start drilling on the data. Transportation and distance are a much bigger deal in Montana than they are in California. Some parts of California, it's a big deal. But, you know, transportation in urban city, most of those places are to the right because there's either, you know, some kind of public transportation or the frequency of having autos. But in places like Montana, it may be a bigger weight. I don't know. We're going to see what the data shows us. But that will be part of the reason for doing something like this in Montana. It may not be what HPI or SVA may not be relevant. And if that's true, then, you know, do we need state specific indices? Just because these unique things are so important to tease out, that's really important to be able to do that.
Great comments. And there any other questions? Anyone who would like to come off mute and ask a question?
Oh, that's a good. So Alex asked this ROI question. I've heard this. That if hospitals don't find an ROI on working on social determinants of health or improving outcomes, they're not going to do it. Maybe. I don't know. I mean, I have different feelings about that. I think at some point, people are embedded in their community, want to take care of their community, and, you know, if it's life or death, if they're on a teetering of financial solvency, maybe that's they won't be able to have the bandwidth or the financial resources to be able to do that. But I don't think that's where most hospitals are. I think everybody wants to take care of their community. They're committed to their community. Most of them got the business. They want to help their community. Yeah, they have to, you know, you have to make payments and all those kind of things. But that's my take. I could have rosy glasses, but that's kind of how I look at it.
But you know, Bruce, to that point, it is the ROI can also be, how does the hospital position themselves as the true thought leader and the change agent in those communities? Because if you can drive policy change in those communities, I think that is where you can also fortify your standing in the community as you do that. I think there's a lot of ways outside of, you know, how can we quantify an ROI? There are some things we can't quantify, but they really do help in positioning, seizing, and strengthening that position as the real leader. And there are benefits to that. And if you can convince policymakers to make appropriate investments, it will lift the community, and that will help, you know, the scope of how services are delivered, but who's covered and things like that. So I think it's worthy of an organization to really mine out what are the opportunities that come from this.
That's great. Oh, you're getting lots of kudos from lots of folks. Absolutely, Rich. I think, you know, I've never seen a hospital CEO that isn't worried about their reputation. And that's for better and for worse, right? And if there's ways to advocate, like Rich is talking about, if there's ways to strengthen their community, if there's ways to strengthen the role of the hospital in their community, that's a reputation beneficial thing. It's hard to put money on that, but I know everybody worries about that. A lot of CEOs lose sleep about their reputation. They're worried they're going to show up on 60 Minutes or on the headline of a newspaper in a negative way. Let's see if we can build it the other direction. So I do think there's, whatever that ROI is, it's real from that standpoint. Yeah, this is great.
Yeah. All right. Well, I think we're coming up at the end of our time here. So I just wanted to take a moment to thank you, Bruce, for your partnership and for this very interesting presentation. I actually learned a lot as well. It wasn't too high level if I could understand it. So I really appreciate you breaking it down for us. And I think we're all looking forward to seeing what is next and how this information can be used. So thank you.
All right, great. Thanks, everybody.
All right. Take care, everyone. Again, this recording will be available on our website within the next week. And yes, thank you for your time today. And I hope everyone has a good Friday and a happy weekend. So thank you.